ఓ టాపిక్ ఉంది. కొంచెము ఇది గూడా ఉంది మేడం. ఏది మన పోస్టర్ ప్రెజెంటేషన్స్‌లో కొంచెము జడ్జ్ చేయమన్నారు.
ఓకే. ఎక్కడున్నారు ఇప్పుడు?
ఇప్పుడు హాస్పిటల్‌లో ఉన్నాను మేడం. రేపు ఈవినింగ్ ఎళ్తున్నాను.
రేపు ఈవినింగ్ వెళ్తున్నారా? ఓకే.
ఎల్లుండి ఉంది సాటర్డే ప్రోగ్రామ్ ఇది. టాక్
ఆ,
అది.
ఓకే ఓకే.
సార్ స్టార్ట్ చేద్దామా సార్ డేవిడ్ సార్?
Okay, sir. Good morning, all. Today, Dr. Srinivas Jakkinaboyina is a senior consultant and head of the Department of Critical Care Medicine, SLG Hospital, Hyderabad. He is going to talk on diarrhea in ICU. Actually, it is very complicated and very difficult task to manage to control the diarrhea in ICU. And several reasons. It is very difficult to treat the diarrhea in ICU. I think Dr. Srinivas is going to have a talk on the diarrhea in ICU. Srinivas, please start presentation.
Yeah. Thank you, sir. So, good morning all. As Dr. David has mentioned that diarrhea in ICU we commonly see and difficult to identify. Most of them are self-resolving. And identifying a cause is most important to treat the patient. Next slide, please. WHO defines diarrhea as a passage of 3 or more loose stools or liquid stools per day. So for this, we need to have 3 criteria. One is stool frequency, that is, as mentioned, more than 3 stools per day. And the stool weight, approximately it should be more than 250 ml per day. And for consistency, third one is the consistency. So it can be checked with the help of a Bristol stool chart for consistency. Next slide, sir. So usually we need to ask the patient, or we need to, in ICU, we can see the Bristol stool chart. So type 1, type 2, type 3, type 4, type 5, type 6, and type 7. So usually like soft blobs with clear-cut edges, or a fluffy pieces, or a watery is around more than 5, we can tell that the consistency and is soft and loose stools are present. So these 3 has to be there. One is more than 3 stools per day, 250 ml per day, and Bristol stool chart for more than 4 or 5 per day has to 4 or 5, the consistency has to be. Next slide, please. So pathophysiology, when coming into the mechanism, diarrhea, it can be motoric, so osmotic, secretory, and exudative. So let's look into this. More common is osmotic and secretory. So osmotic, what is osmotic is reduced water absorption because of osmotically active substances intraluminally. Short passage time. So basically what happens is osmotically active substances are there, in the gut. Then the water is absorbed more into the gut, and which represents as a diarrhea, and there is a reduced absorption of water into the circulation. So most of the in the gut it is absorbed and increasing the motion quantity. The secretory is imbalance between absorption and secretion of electrolytes, leading to increased water secretion. So here what happens, the gut has a amount of fluid secretion, and it also has an absorption capacity. When the secretion is increased or absorptive capacity is decreased, automatically the amount of water is more, and which causes diarrhea. Next slide, please. So prevalence of diarrhea in critically ill patients, it is approximately 14 to 21%. Usually onset of symptoms occur in 6 days after ICU admission. So, but some patients admit with diarrhea, but usually a patient admitting with a pneumonia, patient admitting with some other symptoms other than diarrhea. So a patient coming with a pneumonia or a trauma, some other things can lead to diarrhea, which prevalence is approximately 14 to 21%. Onset of symptoms occurring 6 days after ICU admission is used, most common. And diarrhea, ICU enteral feeding nutrition 10 to 78%. So when we start on enteral nutrition, it is approximately around 10 to 78%. That is, the rate is very, very high. So, meta-analysis suggested diarrhea was similar in patients receiving enteral or parenteral nutrition. So most of us, we think that if the patient is having a diarrhea, then enteral nutrition might be causing. But the analysis says that if you are giving enteral nutrition or parenteral nutrition, diarrhea is the same. And the enteral nutrition, more than 60% of the energy targets increase the risk of diarrhea by 1.75%. Presence of enteral nutrition has no impact. So beyond small intestinal threshold of nutrient absorption, diarrhea occurs. And also it causes exposure due to exposure to antimicrobials and infections. These are all the various causes. And the most important is also the rapid achievement of the targets. So if you try to achieve very high targets in the initial first or second days after a patient is sick and he is not taking adequate diet, and if you target more than 60% in the first day or second day, then this diarrhea is more. So you can slowly, maybe over next 3 to 4 days, you can achieve more than 60% in this type of patient who are chronically malnourished. So acute diarrhea, it is less than 2 weeks, and chronic diarrhea more than 4 weeks. To differentiate between disease, medication, diet-related diarrhea is useful in whether we need to have an infectious or non-infectious. Next slide, please. So specific intolerances like lactose or sorbitol intolerance and fructose malabsorption, and pancreatic exocrine insufficiency and bile salt malabsorption, hypoalbuminemia, and also severe infections, organ rejections after transplantation, endocrine disorders like thyroid diseases, diabetes, gastrointestinal tumors, and short bowel syndrome are a chronic inflammatory bowel disease. So these are all the causes for the diarrhea. Next slide, sir. So medication related, metoclopramide, erythromycin, and lactulose, sorbitol or magnesium. So we use any patient who is having gastric regurgitation more, we use metoclopramide, and also constipation, we use lactulose, so that these patients, again, if the patient is having diarrhea, and we need to stop these medications. Next slide, please. Yeah. Antibiotic associated diarrhea, approximately 25%. Without colitis is usually mild and self-limiting. So direct prokinetic effect on GIT, erythromycin and azithromycin. Microbial modification with unmetabolized carbohydrates causing osmotic diarrhea, as I mentioned you previously, which is causing osmotic because they have so they can absorb more water. And unmetabolized dihydrobile acids owing to disturbed microbiota, including secretory diarrhea. So that here the secretions are more and absorption by the gut is less. Antibiotic associated diarrhea with colitis is induced by bacterial overgrowth of gut microbiota by Clostridium difficile or rarely Klebsiella oxidose. So usually we see Clostridium difficile in our ICUs. But next slide, please. Immunocompromised up to 10%, associated with abdominal symptoms, pain in right iliac fossa, abdominal distension, diarrhea, along with typical radiological findings, gross thickening of ileal and cecal wall with surrounding inflammatory changes in the immunocompromised. Next slide, please. Diet-related diarrhea. High osmolarity, as if the osmolarity is high, especially if you give 2 calorie per ml or 1.5 calorie per ml in these patients, because osmolarity is very high, so that the fluid will be absorbed into the gut. And bolus feeding and too fast increase to the targets, and post-pyloric enteral feeding increases diarrhea. So nowadays we almost all are using as a continuous feeding techniques. And we also see now, when compared with the previously seen, say, 10 years back, ICU what we used to feed, and now the diarrhea component also is decreased because of various factors, whether feeding methods and feeding type of material. Uh, so bacterial contamination of enteral formula is very rare, and soluble fibers added to the meal can increase transit time, reduce stool frequency, and improve consistency. So oral diet, increased oral fluids, high amount of fructose or sorbitol may induce diarrhea. So extubated patients require a gradual return to normal diet using isotonic fluids and frequent small meals with hypoosmolarity or hyperosmolarity fluids avoided. So next slide, sir. So infectious diarrhea. So determination of the pathogen either via culture or PCR of toxin or antigen is essential. So we do in a specific patients, what we do when the patient comes to the diarrhea to the ICU or developing diarrhea in the ICU, we send this stool for routine checkup whether any oocysts or any bacteria is present, and also we send for a culture sensitivity. We also look for a toxin A and B and the Clostridium, which is most important because it is coming highly infectious to the other patients also. So different strains of E. coli cause diarrhea, but most of them are not relevant for the ICU. Sir, previous slide, sir. Yeah. So hemorrhagic E. coli toxins are similar to toxins produced by Shigella. The incubation period ranges from 3 to 8 days, and the symptoms include bloody diarrhea, abdominal cramps, fever, and vomitings. So antibiotics and anti-motility drugs are contraindicated because they may release toxins. Next slide, sir. So antibiotic associated diarrhea with colitis. So this is most probably is Clostridium difficile, pseudomembranatis colitis, produces toxin A and B. So there is a new strains available which causes very high mortality and morbidity. And we also have seen few cases of pseudomembranatis colitis like Clostridium difficile. Previously in citizens, we have seen almost 4 or 5 patients over a period of 6 months. Uh, and we did not have much of like cluster of cases, but we had a good number of patients. This one. Independent risk factors include antimicrobials, quinolones, clindamycin, ampicillin, and cephalosporins, age above 60 years, proton pump inhibitors, exposure to patients, like infected patients, severe colitis, toxic megacolon, and death all has been reported. Relapses occur in up to 30% of the patients. So we also see viral, fungal, and parasitic diarrhea in patients who are immunocompromised. The presence of severe diarrhea necessitates specific investigations for opportunistic pathogens. Next slide. Yeah. What is the management? We'll discuss separately about the pseudomembranous colitis, but this management is isoosmolar solutions and continuous infusions. That is as a feeding techniques. In cases of intolerances, lactose-free diets, and in patients with fat malabsorption, low fat or medium chain triglycerides containing diets are recommended. Some fibers have been reported to reduce the incidence of diarrhea. There are no data to support elemental diet. Specific therapy is available for pancreatic exocrine insufficiency and some forms of infectious diarrhea. And supportive care with replacement of fluids and electrolytes, isolation precautions to prevent nosocomial transmission. Next slide, please. Yes, sir, this one only. Yes, sir, yes. Opioids as antimotility drugs like Should be avoided in patients with acute dysentery, with blood in stools and high fever, acute ulcerative colitis, bacterial enterocolitis caused by invasive organisms, okay, and antibiotic associated diarrhea with colitis. Cholestyramine may be considered in diarrhea caused by bile acids, malabsorption, patients with cholestasis, short bowel syndrome, terminal ileum resection, and following cholecystectomy. Probiotics and prebiotics can possibly reduce diarrhea, but there are not enough data to recommend their routine use in critically ill patients. Important is that critically ill patients and immunosuppressed patients, Saccharomyces boulardii is not recommended because of several reported cases of fungemia. Because in these patients, if you start in immunocompromised patients, but there is a high chance of infection. Fecal transplantation in multiple recurrent is Clostridium C. difficile infection, but not studied in critically ill patients. Next slide, sir. Water and electrolyte disbalance, hemodynamic instability, metabolic acidosis, malabsorption and malnutrition, and local consequences of diarrhea that need to be avoided or at least recognized early. Higher disease severity scores at admissions and longer ICU stay of patients with diarrhea have been described. So, greater incidence of bed sores occurs in patients with diarrhea, and which again land into complications in ICU patients and also leads to more mortality and morbidity in this patient. Next slide. So as we look into that Clostridium difficile, one of the most commonly tested, but less common in the ICU. But we check all the patients for these toxins A and B, Clostridium difficile. And the IDSA guidelines in 2021 has suggested that fidaxomicin rather than a standard course of vancomycin is used, and fidaxomicin 200 mg given twice daily for 10 days. So it's a macrolide. So they suggested. So till I read this document, I think yesterday only I thought better drug is fidaxomicin, and till now we are using vancomycin only. Vancomycin 125 mg given 4 times daily by mouth for 10 days. Alternative, if above agents are available, then metronidazole 500 mg 3 times daily by mouth for 10 to 14 days. What is the in this patient is the initial diarrhea where Clostridium difficile is positive. They have done a pooled analysis of this drug, the fidaxomicin. They say that increases sustained response of CDI 4 weeks after end of therapy as compared with the standard vancomycin, and the odds ratio is, the confidence interval is 1.09 to 1.24. So it has a good response in 4 weeks when we give fidaxomicin when compared with the vancomycin. And while it used resulted in comparable CDI initial clinical cure, but the confidence interval is 0.96 to 1.04. But there is no difference in the reduction in the mortality. The evidence, however, suggests that there is a did not result in any increase in the drug-related adverse effect. Drug-related adverse effect, approximately the both things are around 1.02. That is, confidence interval is 0.76 to 1.36. Next slide, sir. Next slide. So that is about the initial thing. That means fidaxomicin increases the response rate and initial cure rate, but there is no decrease in the mortality or drug-related adverse effect. There is no difference. Subsequent or second CDI recurrences, Clostridium difficile infection references. Again, he recommends 200 mg fidaxomicin twice daily for 10 days, or twice daily for 5 days, followed by once every other day for 20 days. So same dose he has divided because it's a second episode. Or vancomycin 125 milligrams 4 times daily for 10 days, followed by rifaximin 400 mg 3 times daily for 20 days. Fecal microbiota transplantation also he described in this patient with a second or subsequent. Okay. So they mentioned that it increases sustained response of CDI in 30 days after the end of the therapy compared with vancomycin. In recurrences, there is a clear response rate. Even initially, also there is a good response rate. But at 90 days, it did not show any difference when compared with vancomycin. So it resulted in comparable initial cure rate. Okay, but the confidence interval is 0.94 to 1.14, but failed to show a reduction in all-cause mortality and reduction in serious adverse events. Again, actually, confidence interval is including 1. So fidaxomicin decrease is suspend response, good response in first 30 days, but showed failed to benefit in 90 days, and initial cure rate is good in this patient. Next slide. So fulminant CDI, vancomycin 500 mg 4 times daily by mouth or by nasogastric tube. That means the patient is in shock and severe dehydration and requiring a lot of fluid resuscitation. This type of patients. Consider adding rectal installation of vancomycin. IV metronidazole should be administered together with the oral or rectal vancomycin, particularly if ileus is present. Next slide. For patients with the recurrent CDI episode within the last 6 months, we suggest using bezilotoxumab as a co-intervention along with the standard antibiotics rather than standard antibiotics alone. So this bezilotoxumab as a co-intervention is suggesting for a recurrent within the last 6 months. Next slide, sir. So this is evidence with the initial episode with more than one risk factor. So what are the risk factors is age more than 65 years, history of previous Clostridium difficile infection, and the compromised immunity, severe CDA, and certain types of virulent ribo types are there. So these are all the risk factors, which if it is more than one, then if you the bezilotoxumab will have a improved outcomes in this patient when compared with the no risk factor. Even if you are giving this bezilotoxumab, there is no risk factor, there is no difference, and if you have the risk factor, then only this has a impact of favors bezilotoxumab. Next slide, please. If it is one episode of previous slide, sir. One episode of CDI in the past 6 months, also there is a difference. If there is more than 2 episodes of CDI in the past 6 months, there is a trend towards favor the difference. But the overall, if it is a recurrent episodes, then bezilotoxumab is useful in these patients. Overall, it is useful. Next slide, please. So what should we do? So this summarizing of our class, today's class. So diarrhea, stool frequency more than 300, so 3 stools per day, and stool weight more than 250 grams per day, and the consistency according to Bristol score chart, that is 5 to 7, as we discussed. The first step is, so this criteria considered it is told as a diarrhea, and then step 1, stop laxatives if it is present, fluid and electrolyte status disturbed. So if it is not disturbed, it is called mild diarrhea. If it is disturbed, it is called severe diarrhea. So first step is, here we have a diagnosis and check for the fluid and electrolyte status. First step. Second step, correct fluid and electrolyte statuses. Like patient may have a hypovolemia, electrolyte imbalances, so it has to be corrected. Further diagnostic tests required because you severe diarrhea, we need to send a stool for culture sensitivity, routine, and also see for a Clostridium difficile toxin A and B. So that is one further diagnosis. But if the fluid and electrolyte status is not disturbed, it is a mild diarrhea. Possible infectious diarrhea, immunocompromised patient, bloody diarrhea. If it is not there, or if it is present. If it is present, then again you have to go for the step 2, where you start investigating these patients. So step 3 is most probably it's a infectious diarrhea. Next slide, sir. So infectious diarrhea, and here if it is you take that patient possible mild diarrhea, it is a possibly infectious or immunocompromised or bloody diarrhea. No further diagnosis is required. Okay, it's a mild diarrhea, no further investigations are required. If it's a bloody diarrhea, you have to investigate for the infectious diarrhea. So in the signs of infection is present or not, we need to look. If it is signs of infection is yes, stool workup for Clostridium difficile, search for specific pathogens according to symptoms and risk factors, as mentioned in the previous table and in this article. And no, signs of infection is not there. So respective risk factors like antibiotic therapy, immunosuppressor, and contaminated feeds. If there's nothing, then probably non-infectious. If it is yes, then it's like the contaminated feeds or antibiotics or immunocompromised patients, yes, then again you need to go for a workup. If the Clostridium difficile is positive or other pathogen is present, if other pathogen is present, we need to start on the concerned antibiotics. The Clostridium difficile is positive, as we discussed, this is a little roller chart. So we need to start this patient on fidaxomicin, but he has mentioned in vancomycin and metronidazole. Here, if it is probably non-infectious, it can be colitis, pancreatitis, exocrine insufficiency, etc. So the specific treatment has to be started. Next slide. So in the step 4, either you give a fidaxomicin or metronidazole or vancomycin, these things, then optimizing and observing all cases of diarrhea in the ICU. Check enteral nutrition. Next step is fifth step is enteral nutrition. Nutrition formula, high osmolarity. So what we need to do is we need to decrease osmolarity so that by decreasing the osmolarity, the diarrhea may come down. And high fat and no fibers. This we need to consider low osmolarity, other composition, and soluble fiber enriched products has to be taken. And check medication, non-absorbable sugars, lactulose, high osmolarity substances, oral preparations via tube, especially post-pyloric, should be avoided. And systemic factors like gut hypoperfusion, hypoalbuminemia, this has to be corrected. So optimize the medication list where possible, and optimize the perfusion and nutrition. Be aware of bowel ischemia. Avoid complications like skin lesions and wound infections in the patients. Next slide. Thank you. And this optimization may improve our outcomes in the patients. I think this is the approach we have to follow in this. So thank you, sir. So any questions, sir?
Thanks, Anna. Very nice presentation. Simply you covered in a chart of how to approach the diarrhea in ICU. So it is a very uncontrolled diarrhea. Patient is going into shock. What is the management? Will
What,
it
sir?
cause shock?
Sir?
Will diarrhea cause shock?
Yes, sir. Yes, sir. We have seen many patients diarrhea causing shock.
Okay.
Yes, sir. Because especially this Clostridium difficile patients, they pseudomembranous colitis. We have seen many patients causing shock.
If it is pseudomembranous colitis, patient shock, surgery is the only option, or this sufficient to vancomycin?
Sir, medical management, sir. Surgery is the last option, sir. Surgery when there is a complications only.
Yeah.
Sir has asked some question here.
Any question?
Why 14 days of antibiotics? Sir, ఇది 10 days of antibiotics.
10 days, you said 20 days also should be continued.
Yeah,
right?
yeah. Because if it's a recurrent,
Yeah.
if it is recurrent, then we need to go for a 5 days of therapy followed by మళ్ళీ alternate day 20 days.
Is Predoxamycin is available?
ఇది ఒకసారి నేను చూసాను సార్, అది ప్రజెంట్లీ అయితే అవైలబుల్ అయితే, మరి అది ఇండియాలో ఉందా లేదా తెలియదు. రాత్రి చదివినాను నేను, ఇది నేను చెప్పంగానే చదివేసినాను.
The Predoxamycin is preferable than vancomycin in AKI or CKD?
Yes, sir.
But we are using vancomycin oral tablets in CKD, no? And AKI also?
Yes, sir.
Any questions?
సార్ ఏదో మెసేజ్ పెట్టినట్టున్నారు, కొంచెం చూస్తాను.
So, Srinu, nice one.
థ్యాంక్ యూ సార్.
So, there is no difference between the enteral feeds and TPN parental feeds, sir, for
Yes,
incidence of diarrhea.
Yes, sir.
We found both in both cases in simultaneous type of diarrhea and different type of.
What, sir?
That means enteral feeds means actually loose stools will happens and consistency will be different, na sir, compared
Yes,
to
yes.
parental.
అంటే సార్ ఇప్పుడు మోస్ట్లీ ఆస్మోటికల్లీ ఉండొచ్చు సార్. ఇప్పుడు సెక్రటరీ డయేరియా అయితే పెద్ద డిఫరెన్స్ ఉండదు, ఎందుకంటే అది అబ్జార్ప్షన్ అండ్ సెక్రీషన్ ఈజ్ డిఫరెంట్ థింగ్. బట్ ఆస్మోటిక్ డయేరియా ఈజ్ ఎ పాసిబిలిటీ, బట్ ఇన్ ద పేషెంట్ హూ ఈస్ గివింగ్ enteral feedings, but they found there is no difference, physical evidence.
What could be the reason for parental nutrition and diarrhea due to parental parental nutrition?
Mostly secretory diarrhea, sir.
That is secretary.
Mostly secretory diarrhea is there. And sir, parenteral nutrition we are giving means some gut issues are there.
Take with the husband. Father, mother. Okay, sir. Thank you.
Sir, in a watery and severe diarrhea, that whole bed is contaminating, and it is very difficult to clean that area because of bed sore and all these problems. Are there any gadgets available to put into the
Stool management system, sir.
system is there, but
that is better,
are you
sir.
using? It is not available actually in Vizag.
Yes, available ఉంది కదా సార్, వాడు ఒకడు ఇస్తాడు కదా.
But how far it is worth to use?
Definitely it is useful, sir. For especially in diarrhea in the ICU, definitely it is useful.
Okay.
So Mohan sir is post చేశారు.
For
that is to use
stool management system, Sinu, how much? How much the stool management system?
పైన కూడా అడిగాడు. He told metronomy to give 14 days. Any complications for this? When you told no difference, can you authenticate study sponsored by whom? I think the no difference in terms of TPN versus enteral nutrition, కదా సార్ అడిగేది.
Yes, sir.
సో అది ఒకసారి చూడాలి సార్ నేను ఎవిడెన్స్, బికాస్ దట్ ఇస్ అ మెటా అనాలిసిస్. బేసికలీ మెటా అనాలిసిస్ అంటే ఐ హ్యావ్ టు గో టు ఈచ్ స్టడీ హౌ దే హావ్ డన్. how much is a stool management system అంటే stool management system I think 10,000 ఏమో ఉంటుంది సార్. నేను ఒక్కసారి వాడినాను, వన్స్ ఐ యూజ్డ్ ఇన్ పేషెంట్స్. యాక్చువల్గా if you remember, we went to ECMO, no sir. What he said is he uses most of the patients with the stool management systems on ECMO.
Oh, no.
ECMO పేషెంట్స్ కి ఊరికనే తిప్పడము అది ఇది కాకుండా స్టూల్ మేనేజ్మెంట్
You
సిస్టమ్స్
also
వాడతారు.
mentioned there is a combination of metronidazole IV and oral vancomycin if it is severe diarrhea.
Yes, sir. Yes, sir. IV. Yes.
What about the feeds in severe diarrhea?
Sir, feeds actually should not be stopped, sir. As per the evidence, feeds should not be stopped. See, infection because of the feeds is very less, because nowadays we are not using any kitchen feeding. All are formula feeds. So where actually they are supposed to.
What type of feeds will you change in diarrhea? Means fiber rich diarrhea, soluble fibers will be added more. The high protein will cause more diarrhea, no? What type of feeds you will give in diarrhea?
So diarrhea basically most of the times we use either 1.5 calories, no sir. We have to dilute it. Mostly osmotic. Adding fiber అంటే మీరు ఏమన్నా ఫైబర్ ఏమన్నా దొరుకుతుందా సార్? అది మనం బయట
soluble fiber is there, pentasure fiber, this type of feeds. Yeah, pentasure fiber is available. That is only fiber, so it will mean solidify the liquid, so that it will reduce the secretion and increase the absorption of the gut. So it will solidify the liquid stool and makes like thicken the stool. So soluble fiber is advised in watery diarrhea particularly. And increase the probiotics, like increase the curd like things, no? Probiotic.
Sir, one more thing is you told that vancomycin dose is 500 mg 6th hourly, na sir? CD5, CDI.
125 mg 4th hour, 4 times a day.
Sir, ఇది 125 4th hour day, sir.
125 amma. Okay. 125. Okay. Okay, sir.
If it is very serious, sir, it is a serious, then we can
500
use
also
500
he
mg.
mentioned. 500 also.
500 mg if it is very serious. Fulminant.
You mentioned in one slide 500 mg.
Fulminant.
Yeah, fulminant. Fulminant CDA, vancomycin 500 mg 4 times a day.
Yes.
And metronidazole IV 500 mg 8th hourly.
Yes, sir. This combination is some, sir.
Okay. What about rifaximin?
Yes, sir. Rifaximin is actually recurrent lo ivochu, sir. Recurrent lo.
Only recurrent or the first line of treatment?
The first line of treatment is not that, sir. But usually we can give in recurrent.
All gastroenterologists starting rifaximin in the initial stage itself, no? When patient starts diarrhea.
Yes, sir.
They are giving rifaximin 400 mg or 500 mg TID plus VSL3 BD like that.
అంటే వాడడానికి ఉన్న ఎవిడెన్స్ డిఫరెన్స్ ఉంటుంది కదా సార్?
అదేలే. What is the role of anti-motility drugs and this domperidone?
సార్ అవి స్టాప్ చేయాలి కదా సార్ డైరియా?
అది కాదు, domperidone కాదు. What is that to stop the diarrhea? Loperamide, all these drugs.
అది సార్ అది కొంచెం వాడడం కొంచెం డేంజరస్ సార్ అవి. ఎందుకంటే ఒకవేళ అది దానివల్ల ఒక్కొక్కసారి ఏమవుతుందంటే ఎస్పెషల్లీ దే ఆర్ కాంట్రా ఇండికేటెడ్ అన్నారు. హిమరేజిక్ ఉన్నా కానీ ఆర్ ది పేషెంట్ ఈస్ హ్యావింగ్ అబ్డామినల్ డిస్టెన్షన్ ఇవన్నీ ఉంటే అండ్ హై గ్రేడ్ ఫీవర్ ఉన్నా కానీ ఆర్ ఇది అల్సరేటివ్ కోలైటిస్ ఇట్లాంటివి ఉంటే మాత్రం షుడ్ బి అవాయిడ్ దీస్ థింగ్స్. ఎస్పెషల్లీ హై గ్రేడ్ ఫీవర్ బ్లడ్ ఉన్నదేమో అంటే మాత్రం లోపరమైడ్ ఇవన్నీ అసలు ఇవ్వద్దు.
And if you think it's CD అనుకుంటే కూడా అవాయిడ్ చేయాలి. You will increase the toxin loads, loperamide అలాంటి ఇస్తే. If you think it's because of some food intolerance or like no fever, no toxicity, just watery diarrhea, you may try to give you may try to give Redotril alantidi koda, but if you think it's because of infection with something, you should not give.
But outside everybody using that, madam, loperamide. ఒక స్ట్రిప్ వేసుకొని వెళ్ళిపోతారు ఊరు.
వాళ్ళు మన దగ్గర కొంతమంది ల్యాండ్ అవుతారు కదా సార్,
ఆ?
కొంతమంది ల్యాండ్ అవుతారు కదా.
ల్యాండ్ అవుతారు. ICU we are not using, but outside everybody using this
స్టాండర్డ్ ప్రిస్క్రిప్షన్ సార్, అది స్టాండర్డ్ ప్రిస్క్రిప్షన్,
వెరీ స్టాండర్డ్.
అంటే వాడు అంత సిక్ ఉండడు కదా సార్.
You said quinolones are the infection, the antibiotics causing diarrhea, but for diarrhea they are using quinolones, no? That like ciprofloxacin, metronidazole IV.
సిప్రోఫ్లాక్సిన్ ఏం వాడడం కదా సార్,
Huh?
నార్ఫ్లాక్స్ వాడతాం కదా.
Norflox is the drug of choice kada, but you mentioned quinolones will cause diarrhea.
ఒకసారి డ్రగ్స్
ఉంది స్టార్టింగ్ లో యాంటీబయాటిక్స్.
యాంటీబయాటిక్స్ లో ఇస్త్రోమైసిన్, ఇది తర్వాత కార్బోహైడ్రేట్స్,
ఎక్కువ మ్యాక్రోలైట్స్, కెఫలోస్పోరిన్స్ వీటితో ఎక్కువ వస్తుంది కదా.
అవునవును.
And ampicillin.
Cephalosporins he mentioned quinolones also. ఇదిగో ఇక్కడ see the independent risk factors for including antimicrobials, quinolones, clindamycin, ampicillin and cephalosporin. Maybe patient on quinolones, if he develop diarrhea, we have to stop the quinolones also.
ఈ క్వినలోన్స్ మనం రేర్ గా చూస్తాం కానీ ఇవైతే వెరీ కామన్ గా చూస్తాం కదా సార్. యాంపిసిలిన్, సెఫ్లోస్పోరిన్స్ రెగ్యులర్.
Maybe the quinolones also will cause not more than clindamycin, but
వాడడం కూడా తక్కువ అయిపోయింది కదా సార్ క్వినలోన్స్.
వాడట్లేదు, బట్ నార్ఫ్లాక్స్ ఇవన్నీ వాడతారు కదా. Okay, cephalosporins very commonly used antibiotics in ICU. If patient develops diarrhea, will you stop cephalosporins?
అంటే ఇప్పుడు దాని వల్లనే అయిందని మనం చెప్పలేము కదా సార్. ఇది వీ హ్యావ్ టు చెక్ ఆల్ ద అదర్ థింగ్స్.
Finally, we have to think of antibiotic to rule out everything.
One of the most commonly used modes are better. Loperamide is dangerous.
Dangerous కానీ బయట అందరూ వాడతారు కదా. ICU లో dangerous, but what about outside everybody? మెడికల్ షాప్కి వెళ్తే ఫస్ట్ అదే కదా ఇచ్చేది.
అదే ఇస్తారు సార్, అదే ఇస్తారు.
ఓకే అన్న, ఎనీ క్వశ్చన్స్ ఫ్రమ్ ఆడియన్స్? If there are no questions, I will close the session. Thanks Anna, you answered all the questions, and thank you and all the best for your national conference.
Thank you
all for your active participation. Thank you.